Tana nanti lagging. Not very smart. AI ni not very AI. Okay, Assalamualaikum, very good afternoon everyone. Okay, so we are kicking off CME session balik because I think it's been a while since we've had good CME sessions. We'll try to do it every week, inshallah. The topics are already given. It will be all core cardiology topics. Sometimes we will try to get interventional topics juga, but mainly catered for everybody, NICL, ICL, MOs, fellows, okay? So this week, we'll be talking about something along the lines of the preventive cardiology theme, okay? We'll be talking about exercise prescription and cardiac rehab. Dr. Fateh will lead the way. Next week will be about heart failure and iron deficiency. So we have Shazwan. Shazwan is the other one. Shazwan. You have Shazwan who's doing that topic, right? Okay, so that one should be sorted. That should be a Friday. But today, minta maaf, we had to ask for it to be done on Thursday because I'm not around tomorrow. Okay, so without further ado, I'd like to introduce our speaker, Dr. Fatin, who will lead the way. She has 43 slides to go through. Boleh share screen?
Share screen lagi. Macam dah tadi.
Okay.
Dah already share screen. Okay, got. Assalamualaikum and very good afternoon. I bid to all cardiologists, member of the floor, my friends. So today our CME is about exercise prescription and cardiac rehabilitation following cardiac disease. So
First slide that will be transition. So out. Okay, and then your share to share your own post screen. Yeah. So stop presenting. Okay. And then share. Okay, share your whole window entire screen. Alright. Okay. And then you go back to your point. Okay, and then entire screen back.
Alright. Okay. Sorry. So this is my outline. So we will be discussing one case study, introduction regarding exercise prescription and cardiac rehabilitation, and recommendation by EAC guideline, and also based on CPG in Malaysia. So okay, so this is a case study. Mr. F, a 31 years old gentleman, previously no non-medical illness, active smoker, presented with central chest pain, crushing in nature, diaphoresis radiating to the left, upper limb with pain score of 10. Vital sign, a bit of hypertension, not tachycardic, febrile, DXT is 17, so we expect this patient might have newly diagnosed diabetes mellitus. ECG show ST elevation lead 2, 3 and LVF. So this patient successful thrombolysis with streptokinase, ECG after thrombolysis show more than 50% reduction, proceeded with COROS, and it showed that 90% RCA block, 30% LAD, and proceed with PCI to RCA. Okay, so from this story, we know this patient is a young patient having acute coronary syndrome, successful thrombolysis and successful stenting. So what should we do next for the cardiac rehabilitation? So we will be discussing about cardiac rehabilitation, and before that, so cardiac rehabilitation, I think some of us already know regarding geriatric rehabilitation, pulmonary rehabilitation, stroke rehabilitation, post-stroke rehabilitation. But I think this one, cardiac rehabilitation, is something that new kid in the block, which is some of us may not even familiar. I also is not familiar with it before this. Sorry, doctor. So in cardiac rehabilitation, it is evolving. Previously, we only do cardiac rehabilitation only inpatient, outpatient, and some now there is study that they did the cardiac rehabilitation hybrid, inpatient, outpatient, and also they also did a home cardiac rehabilitation. So first, we go to exercise prescription. So how to prescribe? Okay, how to prescribe exercise prescription in cardiac rehabilitation based on frequency, how often, how many sessions per week, intensity, how hard, time, how long, and type, mode, and what kind of exercise should we prescribe, whether it's endurance, resistant, aerobic or anaerobic, isotonic or isometric. So before we start giving exercise prescription, there are some things that we need to reconsider. So what are the factors that need to be considered? Safety factor and associated factor. So from the clinical history, the risk associated with coronary vascular disease progression or instability and exercise participation, degree of left ventricular impairment. So patient with ejection fraction of 35% is not similar for ejection fraction of 58% for the exercise prescription. Ischemic and angina threshold, cognitive or psychosocial impairment. So associated factor, either vocational or avocational requirement, whether patient wanted to do or he have to do it. Orthopedic limitation, patient having osteoarthritis or patient having lumbar spondylosis, so there is limitation for the exercise prescription. Previous and current activities, personal health and fitness goal. So what is physical activity and what is exercise? It is not the same. Physical activity means any bodily movement produced by the contraction of skeletal muscle. So anything that we do that can increase energy expenditure above basal metabolic rate is physical activity. So exercise is a plan, is a structured and repetitive bodily movement which is done to improve or maintain one or more component of physical fitness. Okay. So these are component of the exercise training session in exercise prescription. So before initiating any exercise training, we need to do a warm-up, at least 5 to 10 minutes of light to moderate intensity, cardiorespiratory and muscular endurance activity. Why? Because we want our heart or our cardiovascular system to adapt with the exercise training and prescription. Conditioning, at least 20 to 60 minutes of aerobic resistant, neuromotor and or sport activities. Cool down at least 5 to 10 minutes and stretching at least 10 minutes of stretching exercise. So these are the FIT principle of prescribing aerobic exercise. So based on frequency, intensity, time and type. Okay, these are example from American Club of Sport Medicine regarding cardiovascular exercise prescription. So name of the patient, what is the RN number of the patient, what is the date and age of the patient. So mode of activity, so depend on the factor, associated factor of clinical history of the patient, we can prescribe this type of activity. Duration, 20 or 50 minutes, frequency and intensity, progression and also special consideration. So these are example of classification of sport intensity. So intensity, it can be low, moderate or high intensity. So based on this, we can recommend patient what type of activity or what type of sports they can do. So this is also the same, high, medium and low exercise based on skill, power, mix and endurance. So generally according to EAC guideline for exercise sport in healthy individual, they are recommended to at least 150 minutes per week of moderate intensity or 75 minutes week of vigorous intensity aerobic exercise or an equivalent combination, which is recommended in healthy adult. So this is evidence by class 1 and level A, which is recommended, and there is a clinical trial that proven that this exercise can be done in healthy individual. So moving on, cardiac rehabilitation. What is cardiac rehabilitation? It actually consists of coordinated multifaceted intervention designed to optimize cardiac patient physical, psychological and social functioning. It is not only it is a multidisciplinary approach, which is we need cardiologists, we need rehab specialists, we need physiotherapists, we need occupational therapists to participate for cardiac rehabilitation. It is comprehensive long-term program involving medical evaluation, exercise prescription, cardiac risk factor modification, education and counselling. These are the core component of cardiac rehabilitation. So why? Healthy behavior changes and education, lifestyle risk factor management, physical activity and exercise, diet modification, smoking cessation, psychosocial health, medical risk factor management, long-term management, audit and evaluation. So it is multidisciplinary approach which need a multidisciplinary approach which need different parts of subspecialty. So cardiac rehabilitation has exercise has positive effect on several risk factors for arteriosclerotics. Regular exercise reduces the risk of many adverse health outcomes irrespective of age, sex, ethnicity or the presence of comorbidity. So it shows that 20 to 30% reduction of mortality in adverse event compared with sedentary lifestyle. So, in cardiac rehabilitation, these are general recommendation for healthy adult, which is 150 minutes per week of moderate intensity. So, in patient with coronary artery disease at low risk for exercise-induced adverse event should be considered eligible for competitive or leisure sport activities. In case of patient with high-risk CAD, competitive sport are not recommended because of the adverse event and also residual ischemia. Okay, so these are the recommendation for exercise in hypertension, DM and obesity. So why exercise prescription is important? Because according to the recommendation, it can reduce the intra-abdominal muscle mass, increment in muscle and bone mass, reduction in BP and chronic inflammation. By doing the resistant activity or aerobic exercise according to prescription, it can improve insulin sensitivity, improve the lipid profiles, improve the glucose tolerance and also physical fitness of patient. So in older people, as we all know, geriatric age group, which is more than 65 years old, they are usually decreased in body mass, sarcopenic, and prone for frailty. So it should be designed according to their biological age, exercise experience, functional capacity, safety aging trajectories, comorbidity and lifestyle habits, and also previous experience of exercise. Should they have a specific exercise prescription so that can fit for their condition. So exercise activity for older people according to exercise type and intensity. So these are the example. Age-related moderate effort activities, age-related intense effort activities, muscle strengthening activities. Okay, so the recommendation from the EAC, it state that 65 years old or older who are fit and have no health condition that limit their mobility, moderate intensity aerobic exercise for at least 150 minutes per week is recommended. Okay. However, if there is a risk of fall, strength training exercise to improve balance and coordination at least 2 days a week are recommended. So, but this one, a full clinical assessment, including a maximum exercise test, should be considered in sedentary adult aged 65 years old older who wish to participate in high intensity. But this recommendation is this recommendation is level C, meaning that it is only recommended from specialists or expert, which is not included in any clinical trials. So acute and chronic coronary syndrome. So this topic mainly we want to stratify. We want to know which patient, whether patient is low risk asymptomatic, patient is in chronic coronary syndrome, patient is acute coronary syndrome, how we want to stratify and how we want to prescribe cardiac rehabilitation for this patient. So first thing first, in patient in acute and chronic coronary syndrome, first stratify the patient. Is the patient is very high risk? Is the patient is high risk? Patient moderate risk? Or the patient is low risk? So after we stratify according to this guideline, we can give a recommendation or exercise prescription for the patient according to the cardiovascular disease.
Score classification.
Score ni this one, this score.
Score is for people without disease.
Yeah, so if they have disease, then they still have high risk. But previous
And then we have our own like
Asia Pacific. Ada. Yeah, got.
Asia Pacific score.
Asia Pacific score.
No, score just
To guide.
score paper just released masa DSC Sofian Jafar presented the score Asian calculator, which validates score algorithm to Asian population in Brunei, Taiwan, Singapore, and Indonesia. They skipped Malaysia, even though Malaysia had the largest cohort of 100,000.
Shani was part of the new. Shani was one and you had contributed.
They skipped them, so they went to Umbi and got the Malaysian cohort 100,000 population. Now, from that paper, Score Asia is good depending on your setting. So when you talk about risk score, because I do a lot of work in risk score, you have to be a bit careful in how you word it. Patients after heart disease, they are already at high risk. Okay, so you can apply score calculator to patients who already had a heart disease.
Okay.
They already automatically high risk.
So you already have the documented ASCVD and all that, right?
Okay.
Very high risk.
They're already high risk. So it doesn't make sense.
Okay.
But if you're thinking in your day-to-day clinical work of risk stratifying your patient, then there's another algorithm to risk stratify them for exercise prescription. That's the one that you should be touching on. Ada kan money?
Ada kot. Ada kot.
But you must understand what is score used for. This for patient that you do in clinic without heart disease, without known. Then you want to know what's their risk of dying lah, or experiencing cardiovascular event. That is called FRS, or RPCE, WHO. All these are risk factors validated, and it perform in different manner. So for us, Malaysia, the one that performs best is not Score Asia. Score Asia was good from a bragging point of view, saying that score has been validated in Asia. Tapi dia tak guna data set Malaysia pun, dia guna Brunei, Indonesia, Singapore, and Taiwan. Okay, they skip Malaysia even though they had access. So far, the best performing is still FRS and RPCE.
Right. Okay. Okay. So next, this one. So from this table, after we stratify CBD risk, this is actually about, as per Prof. Sazli said, in a patient which is came to the ward or came to the clinic for screening test lah. Basically, they want to do activity. Doctor, I want to do exercise sport, whether it is low, intermediate, high, or very high exercise. So we want to stratify whether it's safe or not. Right, Prof?
Yeah.
Okay. So the CBD risk based on the score, whether it's a low CBD risk or very high CBD risk. So if it is low, no further investigation according to the AAC guideline. If it is high or very high CBD risk, so we have to do intensity of physical. We have to re-stratify, or we have to know what the intensity of the physical activity that the patient wanted to do, whether it's a low, intermediate, or high, or very risk. So if it is a low or intermediate, no further investigation needed. But if it is high or very high intensity of physical activities, then we need to further test the patient with some modalities, maximum exercise test or functional imaging, CTCA or CTCA. So let's say it is positive or high risk features, then we have to proceed for invasive coronary angiogram to know what is the status of the coronary arteries. So let's say if the cardiac imaging or maximum exercise test is normal, no further investigation or restriction needed. Okay. So as we all know, exercise-based cardiac rehabilitation reduce cardiac mortality, hospital readmission, and anxiety. So we have to refer certain case. For example, in ACS, cardiac surgery post PCI should be early referred to exercise-based cardiac rehabilitation program soon after discharge, or actually it is inpatient and then continue as outpatient for the exercise-based cardiac rehabilitation. The duration is about 8 to 12 weeks after the cardiac event. So this is the recommendation.
So maximum exercise test macam stress test.
What is activity? What is activity? You don't go through that.
Tak sure.
So activity
Yes,
is basically condition. That's what we would say. So your typical exercise stress test ada loose protocol, but that's not the maximum. So no people ask Abang Man to just continue the patient since his tires out, and then you will look into the final ECG.
Just to let you know that
Same thing, except that it's until condition, meaning that you don't stop until the patient says he has to stop.
Okay.
So slightly different prescription, slightly different order in your system when you ask Abang Man to do it. Anything, flexible exercise test when you want to assess for sports.
Your patient juga lah.
It's patient, it's memang patient dependent. So they will tell you when to stop.
So kalau stress test ni, you ada 4 protokol tau. So one that we commonly use for our patient for testing our functional schema is cruise. So cruise ni, they have to pass 60 minutes, which is stage 2, for them not to have a mortality risk of like 50% in the next 2 years. That's how strong cruise is after stage 2. Kalau you tak pass stage 2, meaning that you are at risk of dying. That's rule number 1 for cruise. Kalau you buat cruise, then automatically when you look at the stress test, you have to calculate your stress test for ETS. ETS ni you calculate the number of minutes exercise minus symptoms of angina 0, 1, 2, 3 minus maximum ST pressure. Okay. So kalau di tracking score you katalah 10, it's very good. Kalau di tracking score katalah minus 2, so it's again another tool for you to risk estimate your patient, so that when you see them in clinic, you have a conversation. Stress test ni is high risk, then you should do functional testing on anatomical testing, angiotensity. To bruise, tapi separuh orang dia tak boleh menggunakan bruise protocol, so you have to do modified bruise. Modified bruise, the next one is counter protocol. These are all protocol designed to orang sakit lutut dan orang tua. So what it means is that instead of treadmill 2, base dia start dengan 3 incline 1.
2.7.
2.7.
So every minutes dia akan naik. Kalau dia mau terus, dia tak laju. Tapi untuk
tak bruise itu bruise.
Bruce 2 dia inclination dia macam 4.0. Tapi dia punya speed dalam 2.7.
Dia naik sikit.
Dia naik sikit.
Kalau modified bruise, the stage, first stage, second stage, inclination naik, speed maintain. Kan?
Yes, sampai stage 3 speed maintain.
Stage 3, inclination naik lagi, speed maintain.
Stage 4 baru dia macam stage 2 standard Bruce protocol.
And then dia masuk, speed dia naik sikit. So kalau your patient boleh sampai stage 4 for modified bruise, dia sambung jump stage 2 of bruise. So dia half, which is graduation. Okay. So useful kalau patient have CAD, heart failure, movement problem, orang tua. Yang nocturne pula, nocturne ni sangat slow. Ini macam tua yang you have no other test nak test the functional symptom. So dia punya speed tu is like 1. Dia macam tegak-tegak lah, dia tak gerak pun, and it's very flat. And as you move on to the next stage, decline the next sikit, dia laju sikit. Tapi dia laju, dia punya progression is a lot slower than modified bruise. So that's how you utilize your stress test. Jangan order stress test saja. Nanti kalau technician tu junior, dia boleh MSU, tak tahu nak buat apa, dia bantai modified bruise atau bruise. Sesil dia bawa depan dia. Yeah, so you have to be aware of how you order test kan. The problem is bila you order test kat clinic hari ni, test tu buat 6 bulan lepas akan datang. So association ni kurang sikit. There is some logic for you to do your test. Itu untuk orang sihat. Kalau orang sakit jantung, selain kita pula dengan exercise protocol.
Right. Kita continue. So, in patient for asymptomatic patient but have risk of CAD, we have to use the score risk stratification and clinical evaluation based on the previous table. So, either it's normal, borderline or inconclusive test. So, if it is borderline or inconclusive test, EAC suggests for stress echo or cardiac MRI. If positive, straight for invasive coronary angiogram. So recommendation by EAC, they said among individuals with asymptomatic chronic coronary syndrome defined as coronary artery disease without inducible myocardial ischemia on a functional imaging or conventional exercise stress test, participation in all type of exercise including competitive sport should be considered based on individual assessment. So again, we have to stratify the patient. So these are inpatient who is having inducible myocardial ischemia. If this patient is having inducible myocardial ischemia, we have to do coronary angiogram. Risk of the coronary lesion, whether it is a low risk or a high risk lesion. If it is low risk, asymptomatic, EF is more than 50%, no exercise-induced arrhythmia, so this patient is under low risk, can participate in intensive exercise program. Although some restriction may apply, so this is based on recommendation and also based on cardiologists who attend the patient and also special care. So let's say high risk lesion, if it's more than 50% LM stenosis, more than 50% stenosis at LAD or 2 to 3 vessel disease, or more than 90% lesion in a vessel, so we have to revascularize the patient. So let's say the revascularization PCI is possible and patient is asymptomatic, EF is more than 50%, no exercise-induced arrhythmia. So this patient, after the revascularization, he fell under low risk group and can participate in intensive exercise program. But again, need recommendation and need follow up and need cardiologist or sport rehab recommendation and follow up. Let's say the revascularization is not possible, patient is having symptom, chest pain or ischemia despite medical therapy, then patient only can participate in skill competitive sport and mild to moderate intensity leisure sport.
So it is important, this is the most important slide I think of Martin's when I saw, because our preference I think is to be revasc all our patients. The question is when we say revasc as an revascularization, it's full revasc. Kalau patient 3PD, we have tackled all 3 vessels either by MH or by PCI. Okay, and the big debate also is you revasc ni, you gonna imaging ke tak guna imaging, and you done a good job, you don't know. You don't know if you don't use imaging. So this is where it gets a bit contentious. More for us is the fact that we leave some of the lesions alone. We tackle the target, prognostic vessel, but we also target the target lesion, the culprit lesion. Okay? And we may want to just go and clear the other patient. That is very important to note because then your exercise prescription matters. Whether your patient can go all the way into high intensity exercise. Choice of exercise is very important. This is something that is lacking in our center at the moment. Our patients go through CRP, a rehab program, but when you see them after 6 sessions of CRP, they still don't know what they can actually participate in. I mean, the rehab is good for sure. Then they build some confidence. But when you build the confidence, the patient next step is they want to start cycling balik, they want to start bersukan balik. They don't know what kind of sukan they can actually participate in. So that's why it's important for us because I don't think rehab has gone through that in much detail. Okay, so we need to know. One of the pictures yang Martin showed earlier, that picture is actually from the Asia Pacific Society of Cardiology Netherlands. That is specifically built for the Asian population. So they say sepak takraw is there, for example. So they actually look into sports yang kita ada kat Malaysia and how we can advise, which kind of exercise we can advise. The big question is kalau patient nak main sport juga, nak high intensity sport, and the patient has 2 remaining vessels like asymptomatic, are you going to open up the 2 vessels so that the patient can actually play the sport?
Based on this kind of patient. Kalau
So you've done the target lesion, patient ada 2 lagi, patient dah CRP apa semua, then patient say I want to go and back to like competitive cycling, nak buat itu dengan kali. Are you going to open up the 2 vessels just for that sake?
So in this case, whether you want to do another functional test or you can.
So if your functional test has anything, but you know that there's lesion, right? There's nothing about functional.
Fully in patient.
So you will fully repass.
It's the high exercise, so I will consider fully repass. Just please share like that.
What do you think? Because I think there's no evidence for that.
Evidence just
It makes you feel good. Kalau the pingsan, they say I done my job already.
the problem is that you have to understand your risk of sudden death from heart disease. You get it when you are under 5 years old, and then 5 to 15, you have a risiko rendah, and then from 20, it starts to rise in a very linear fashion. By the time you reach 60, it jumps up. So then the risk of sudden death grows in exponential manner. So that's the reason. That's number one. The majority of sudden death that occurs between the age of 25 to 90, 70% is driven by coronary artery disease, 70. Okay. As you get younger, the causes of sudden death will you start seeing myocarditis, hypertrophic cardiomyopathy, channelopathy, then making up between 40 to 50%. The rest are coronary artery disease. Okay, so understand that fundamental first, because then when you have a 25-year-old, kita lah Azizul Asmi, cyclist kita. So he has an anomalous right coronary artery coming out from the left side, intraabdominally cause. Maksudnya, historically, ada risiko suddenness, especially kalau symptom. Now, he's a high output athlete, during training gila-gila semua. Tak pernah ada symptom. Tak pernah pingsan. Tapi this time dia ada chest pain sikit kan? I think that triggered the cardiac. This time dia ada chest pain sikit. Previously tak ada chest pain also. And he's able to complete all the number medal blah 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 semua, tak ada pun mati. So you revascularize him dulu, and you revascularize him sekarang, outcome dia sama. Nampak? So that's why as sekarang, when you have somebody who has documented coronary artery disease, who is a previously healthy, fit person, able to do everything without symptom, sometimes revascularizing them may not change their trajectory. But sometimes when you don't revascularize them, and then something happens, they will point the finger at you. So this is the conflict that we doctors face. Should we or should we not revascularize? Okay.
But there's no evidence. There's no evidence. Normally, when I spoke to EJ, they said memang they will try to advise the patient that try and reach compromise the type of exercise that is more feasible for the patient. So they might not be able to go and do their
So this is where the level of activity plays a role, because high intensity activity like marathon training, triathlon, and they are chronic activity, and we know this because some of us doing this well. They induce inflammation, and when they induce inflammation, it causes a plaque to be unstable. And you don't actually pain, and you get ruptured plaque because the plaque is unstable, and that is the cause of coronary rupture. Sebagai sing, as an example, healthy cyclist mati, mountain migraine infarction. Okay, so that is a mechanism of plaque rupture in healthy people. It's not that maybe dia tak screening, maybe dia bila dia exercise makan lebih sikit, maybe dia exercise tapi dia jaga gila-gila badan dia, tapi still ada coronary disease. Possible. And the mechanism is such that because chronic exercise causes an inflammation response to the body. That's why bila you nak masuk aktiviti ni, you kena tak boleh lah terlebih. Dia nak.
So tak ada rules lah patient. So after revas, before patient go back, macam athlete kan, macam ni, patient safe to participate in the event. So tak ada pun nak kena buat fine.
So listen yesterday video webinar. I think Lucky does CPAT lah. So CPAT gives you the most gold standard of measurements for vehicle max, which then tells you the oxygen. We don't have it. So one of the questions we wanted to ask him was, what is a replacement for vehicle max? Obviously that's not a replacement lah. But a stress test and all that, it's a reasonable alternative in a setting where you don't have CPAT. But we do have CPAT actually in Malaysia. Itu tak business kan, but it's in certain centers saja lah. So if you want, then you refer them over for CPAT evaluation to help with the exercise prescription.
Sports FSS are discipline.
Right, it's either research or it's in private center. So recently I expect IGN and CPAT lah because they're building up their sports punya unit. So a few places have invested. UM has a CPAT. Boleh hantar kat OZ. So yeah, a few people. Okay, go ahead.
Alright.
Okay, go ahead.
Okay. So in the guideline, they are given some recommendation and table that said that high risk feature for exercise-induced adverse cardiac event in patient with atherosclerotic coronary artery disease. So this patient we have to be careful in giving exercise prescription. In case of critical coronary stenosis more than 70% or more than 50% in the left main stem, angiogram, or FFR less than 0.8 or IFR less than 0.9, basal left ventricular ejection fraction less than 50%, and wall motion abnormality, inducible myocardial ischemia on maximal exercise testing, non-sustained VT, polymorphic or very frequent ventricular premature beats, and resting during maximal stress, and recent essays of PCI or surgical revascularization. So this patient we need to be careful in giving exercise prescription or cardiac rehabilitation.
Right. So some people use governments kat Singapore, but the point here is kat klinik ada yang cakap boleh exercise walaupun patient baru je PCR. So that's what I saw that day lah. So actually you do need to give them a bit of time before you tell them they can do full exercise. This is not any high intensity
It's
exercise.
moderate to high intensity.
High risk.
High risk intensity.
This is mainly for high intensity exercise. Again, ESC guideline is very clear. Everybody with cardiovascular disease should participate in moderate intensity exercise at the very least. Okay, so yang tu tak boleh nak lari kan. So it's not that exercise. Type of exercise that's when you help gainer lah.
It is not advised them not to exercise.
Yeah, yes. Moderate at least.
But they must know. You must know how to teach them to exercise. Don't hold by mind. Ada jenis yang pemalas tapi perlu buat. So itu you have to get them how to get to exercise. Itu satu. Ada yang jenis memang high output athlete, bawa kena MI. Nak balik exercise next week juga sebab dia kuat, dia Ironman, dia nak juga buat Ironman. And so you have to tone it down and you have to teach them how to get back into training. Whatever it is, you start by regulation, by mobility, increasing mobility, endurance, maksudnya berjalan. Okay, and then you build it up from there. And then you teach them how to listen to their body. So kalau that's where cardiac rehab yang phase 1, 2, 3, 4 ni is very important. Because that is where the teaching and education of the person to desensitize them of what has happened and what to expect happens. Dan ni korang tak buat because korang tak kisah pun because we are doctors, we are technician, or we are nurses. Actually nurses yang kisah, doctors yang kisah. Tapi we have to change lah because when we don't care, the patient can come back with still smoking, still makan nasi lemak breakfast, sakit hati. So this is your role.
Okay, slide 2 is focus on high intensity, 12 months.
That is just high risk.
High risk.
So therefore, if it's high intensity, definitely you want to avoid lah. But moderate can still be considered. 12 months also, it's actually 6 to 12 months. Okay, go ahead.
So this is a cardiac rehab in post STEMI patient from CPG guideline. So we have phase 1, phase 2, phase 3 and phase 4. So usually as soon as possible, acute phase inpatient after 48 hours of hospitalization, we have to encourage early mobilization. Phase 2 convalescent phase, continue the program started in the phase 1 until myocardial scar has matured. And phase 3 is the training initiated after the healing is complete, which is usually this one is already in outpatient setting, and the patient is safe for aerobic exercise. Phase 4 is maintenance, which is home-based regular exercise to maintain aerobic condition.
So that's what for your app is targeting phase 3 to phase 4?
Phase 1.
Phase 1 early ah.
So the problem with our patient right now, that bila dia masuk hospital, dia yang ni cakap apa dia kata, si jantung, dia duduk, oh dia tak ada apa lah. So kira okey lah, ayah dia kan. Walaupun dia cungan-cungan sebagainya. So that is the mentality of our patient. So the thing that we try to develop, and we started about since 2020, is to try and teach them in a remote manner. So that's why you will now see all this QR code putting on the boards for patients to download the web app and get them to download the web app. You guys can download the web app. So right now, it has education information. So there's a lot of articles in bahasa for them to read, try and understand the disease. So that's an education. Phase 1 is education. It's usually masa kita sebelum balik rumah. Okay, phase 1. So biasa ada nurse educator yang datang, Sensiana ke, Wendy ke, Salihah ke, datang, jumpa patient, and orang patient cakap, okay, you sakit macam ni, kita makan ubat ni, kalau simptom sini, kita datang sini balik. That process should happen. Right now we are trying to jalankan, tapi yalah, macam biasa, susah sikit. But kadang-kadang ada gaya saya. So now we try to digitize it. So mana yang boleh guna app, dia guna app. Yang mana tak guna app, kita masuk dalam phase 1. Itulah. So that's phase 1. Phase 2 is when they come back to rehab clinic. Rehab clinic, the therapist, the rehab specialist kan duduk dengan dia, reassess the risk and decide on their goals for the 6 weeks. Kadang rehab biasa in developed countries 12 weeks kan. Minimum 12 weeks, 3 months, 4 months. We we don't have that time. So we cut it by half, 6 weeks. Tapi yang mana patient yang go through cardiac rehab, which the majority is post cardiac surgery, and post PCI jarang masuk cardiac rehab. They like it because they understand the body better, they feel trust, they feel confident, and they have friends. These are the things that we don't have time to spend into that. But this is the thing that you have to train your mind to.
And I think what is macam kita discuss patient with the bisopolar kan, so patient exercise, so dia heart rate kan. So what is the advice on that? Bisopolar dia, beta blocker dia, beta blocker.
Because there is some benefit. Of course, the big question yang keluar study tu is post MI after 1 year, whether you should continue when the EF is preserved. So that's the contentious. This was a one paper in New England journal doesn't mean that you change the practice. There's also data to show otherwise. Okay, in terms of beta blockade exercise, you just exercise. There is no decision to say, but we're going to assess during your maximal exercise tolerance test episode. Of course, I need to then we'll have to stop the beta blockade prior to testing so that you can have a good interpretation. Interpretation of the test, yes, you might stop the beta blocker. Long term, you should continue. Data about after 1 year, kalau EF preserved post MI, that is a big question mark now. That's what people want to explore further. One paper showed that you shouldn't have to continue. Other papers have shown that there is some benefit to rewarding. Okay. Next. Mana lagi ke?
So ni tak perlu kot. This is the same thing. This is a patient high risk during cardiac rehabilitation. Who are the patient that we have to identify? Ischemic risk patient and arrhythmic risk.
This one, since we're recording, you guys can have a look at later lah.
So contraindication to exercise training. So these are contraindication to exercise training. So patient who are unstable angina, uncontrolled hypertension, orthostatic blood pressure is more than 20 with symptom, significant aortic stenosis, patient is having fever, uncontrolled atrial or ventricular arrhythmia, uncontrolled sinus arrhythmia, pericarditis. So basically this risk patient because it will cause harm than benefit to the patient. So that's why we have to be quite careful with this patient, list of patient. So follow up in cardiac rehabilitation. So in follow up, we have to assess the presence or absence of cardiac symptom and determine the functional class of the patient, evaluate the patient's psychosocial anxiety or depression status and the social integration and support network, review the patient risk assessment, residual ischemia, LV function and current medication need to be reviewed. Treat to target BP less than 140, LDL less than 1.8. Ini daripada CPG. Viral is 1.4. 1.4. It's from CPG. Adapted from the CPG. Okay. Okay, next. Cardiomyopathy and heart failure. Okay. So basically cardiomyopathy and heart failure, fatigue and breathlessness lead to individual restricting their physical activity. Basically in heart failure patient, exercise training mainly three main impairments. Why patient is having heart failure? Because of exercise intolerance due to muscle wasting, leading to loss of strength and endurance, cardiopulmonary and musculoskeletal deconditioning, exertional dyspnea that occur because of increased work of respiratory muscle, increased lung dead space, increased lung compliance because of pulmonary congestion and fibrosis. So exercise training in heart failure is safe and effective. Okay, so the cardiac rehab in heart failure from the CPG of heart failure, we have three phase: inpatient phase, maintenance phase, and outpatient phase. So inpatient, our aim is safe home discharge. Okay, maintenance phase aim to improve long-term survival. How? Cardiovascular risk factor and optimizing the GDMP. Outpatient phase aim to improve functional gains, endurance training, resistance training, and respiratory muscle training.
Kau refer tak patient heart failure for rehab? Why not? Because they are at more risk than what they ACS patients with not poor. You should actually start referring them to Mustafa. She's waiting actually. This has not brought up a protocol.
Patient lah.
The patient, she can gauge whether that patient will need a special program. Have PEP, have REF will work. Have PEP especially benefit from supervised exercise training. Okay, so there's a very specific program that we're trying to ask us to reveal for us. That PEP is as per the guideline yang Dr. Hafiz.
Oh, okay. So, following therapy and risk optimization, heart failure patients should encourage to start the exercise program without delay. So, in case of uncomplicated case, patient hemodynamically not supported, not on a brown, low to moderate intensity recreational sport activity may be considered together with structural exercise program. So, in case of NIHA 1 and 3, aerobic exercise is recommended. If it is functional NIHA 3, so exercise intensity should maintain at lower intensity, and then we can gradually increase the intensity from less than 40 to 50 to 70 VO2 peak. So, high intensity interval training program may be recommended in low risk patient with stable heart failure who want to return to high intensity aerobic and mixed endurance program. So, this is the optimal exercise training dose for patient with chronic heart failure according to frequency, intensity, duration, mode, and progression. So these are the recommendation from the EAC guideline. Class 1, so regular discussion in case of patient of heart failure with reduced HFrEF or mid-range EF. Regular discussion about exercise participation and provision of an individualized exercise prescription is recommended in all individuals with heart failure. So exercise-based cardiac rehabilitation is recommended in all stable patients to improve exercise capacity, quality of life, and to reduce the frequency of hospital readmission. So basically, in case of preserved HFpEF, they recommend moderate endurance and dynamic resistance exercise together with lifestyle intervention and optimal treatment of cardiovascular risk factor. Okay, so in dilated cardiomyopathy, they recommended class 2A may be recommended, which is participation in low to moderate intensity recreational exercise. And regardless of the EF, in the absence of limiting symptom, exercise induce VAs, ventricular arrhythmia. Sorry, ventricular arrhythmia. Okay. So follow-up recommendation, class 1, which is memang recommended. Annual follow-up is recommended for individual with dilated cardiomyopathy who exercise on regular basis. So basically, we have to low to moderate intensity recreational exercise in dilated cardiomyopathy patient. So these are hypertrophic cardiomyopathy. In case of high intensity exercise, where the occurrence of syncope may be associated, may be considered for individuals who do not have any markers of increased risk following the expert assessment. So we need cardiology or rehab specialist recommendation before giving exercise prescription if patient wanted to do high intensity exercise. So recommendation for patient arrhythmogenic cardiomyopathy, the recommendation class 2A, participation in 150 minutes of low intensity exercise per week should be considered for all individual. So
arrhythmogenic cardiomyopathy is not just any dilated cardiomyopathy dengan PFVT, no. This is a specific arrhythmogenic cardiomyopathy, right? Left wings. Okay, so that's a specific condition. For hypertrophic cardiomyopathy, the most important is that increased risk, markers of increased risk. So what are markers of increased risk that you know? No. So markers of increased risk to hypertrophic cardiomyopathy. Kalau ada related to burnout, so that's really correct. So MRI, if the MRI, most of the time mandatory to do one MRI in the entire life of the whole patient. If there's evidence of LGE, that's considered a risk. Okay, typical aneurysm is considered a risk. Okay, LVOT obstruction is also considered a risk. So obstruction 50 millimeter or more. Okay, with Valsalva or even at resting, that is also considered a risk. But the one thing that is of note here, this is a 2020 guideline. Okay, American guideline, which is 2024, have moved away from just saying no exercise. Okay. They have said that actually all hypertrophic cardiomyopathy patients should have exercise, moderate as well. You have to assess your meds. Okay, so it's not completely no lah. Okay, that's right.
So arrhythmia, boleh skip tak ya? Dan habis dah doktor. So ACD, I think this one recommendation for patient with pacemaker. So patient having pacemaker may participate in competitive or recreational sport in the absence of structural or other heart disease which exercise is prohibited. So patient with cardiac device must which sport activity associated with risk of chest trauma should be avoided.
So contact sports normally is a bit tricky. Tapi ada je athletes from Australia who participate in rugby contact sports who have been granted residency because of their business.
Kristen Harrison main bola. Kristen Harrison.
Tapi yang tu contact ni rugby lah. So kita mampus.
Mission on the APT, so APT contact sports here.
So DAPT is a whole different talk on its own whether you can play sports or not. But this one, devices itself still can play contact sport, you just have to risk assess the patient lah.
Contact to aqua.
Contact sport apa? Tak akan short. Jangan risau. It's okay. All good. Water's fine.
Alright.
You can swim, you can swim. Cuma swimming is a problem. Why?
Water.
No, their hand movement tu macam mana tercabutkan wire macam mana?
So it's not recommended lah.
Normally swimmers will not. The other thing with swimming, when you have an ICD, if it shocks and then you're in the pool, you die from drowning. So most of the time swimming tu kita minta tukar alternative sports lah. Cycling ke.
Correct.
Alright, thanks.
I think this is my take home message from EAC guideline.
Yeah.
So according to the coronary artery disease, so these are the recommendation to give exercise prescription for patient with coronary artery disease, atrial fibrillation, valvular heart disease, myocarditis, patient on defibrillator, and one patient on heart failure. Okay.
Okay.
Yeah, thank you.
Okay, go back to the last slide. Okay. So just a reminder for everyone should have at least moderate intensity sports, regardless of your underlying condition. The only one that orang maybe a bit scared about is actually ARC, okay, arrhythmogenic right ventricular cardiomyopathy or arrhythmogenic cardiomyopathy. And two, you have to discuss your patient. The other one is CPVT, so catheter, whatever, polymorphic vascular tachycardia condition too, because exercise induces them. Okay, aside from those two, everyone else should have moderate spots. Myocarditis, 3 to 6 months, no spots when they first diagnosed. After 6 months, with MRI guidance, normally you want to see the leg gadolinium enhancement LGTB now, then you may want to consider spots. Hokum, semua kena ada spot, tapi identify your high risk features yang kita cerita tadi. What else?
Boleh tak?
Apa topik?
Boleh tak print dari kampus tu letakkan?
Ada lagi satu yang cantik juga. The 10 commandments of sports cardiology ESC. That one will be up. Okay. Alright. Thank you very much.
Thank you.
Please prescribe the exercise.
Oh, betul.
Exercise dia.
Oh, betul.
Staff dekat work on behalf ni just
Actually, the stuff is the work. This is they need to be prescribed. We refer to physio and we have selain kita exercise macam pasal kalau model intensity kau tak exercise kau tak kerja lagi. That one is the different completely.
Doctor, stop recording
Yeah, sorry, yeah.
Stop recording.